Hello, myself Professor Khyati Gupta. Here in this video lecture, we will talk about hypolipidemic drugs. Hypolipidemic drugs are the drugs which lower the level of lipids and lipoproteins in blood. Okay. Now, lipid transport, right? But do you know what is lipoprotein? Lipoprotein means complex of lipid plus protein. Okay. So, in lipid transport, lipids are carried in plasma in lipoproteins. After getting associated with several apoproteins, plasma lipid concentration are dependent on concentration of lipoproteins. Okay, so lipid molecules will combine with apoprotein and it will make a lipoprotein molecule. Okay. Now, the core of lipoprotein globules consists of triglycerides or cholesterol esters, while the outer polar layer has phospholipids, free cholesterol and apoprotein, right? So, inner layer of lipoprotein will be of triglyceride or cholesterol esters, while the outer polar layer will be of phospholipids, free cholesterol and apoproteins. Okay. Now, liver secretes very low density lipoproteins, which is VLDL, containing mainly triglycerides and some cholesterol esters into the blood, right? This VLDL is acted upon by endothelial lipoprotein lipase enzyme. In the same way as on chylomicrons and the fatty acids passes into the adipose tissue and muscle. The remnant called intermediate density lipoprotein that now contains more cholesterol ester than triglycerides, right? What is happening? VLDL, that is containing triglycerides and some cholesterol ester, right? But it will act upon endothelial lipoprotein lipase, right? And the chylomicron and fatty acids that pass into the adipose tissue. Same way, VLDL is act upon the endothelial lipoprotein lipase enzyme. Okay, and the remnant called intermediate density lipoprotein means IDL, right? It will now contain more cholesterol ester than triglyceride, right? Clear? Now, about half of IDL is taken back by the liver cells by attachment to another receptor, which is LDL receptor, right? While the rest loses the remaining triglycerides gradually and becomes low density lipoprotein. Okay. Now, if 10 molecules of IDL are there, right, 5 molecules are taken back by the liver cells, right, by attachment to LDL receptor, and remaining 5 molecules will lose their triglyceride content and will become low density lipoprotein LDL, right, which only contain cholesterol ester, right. Now, LDL circulates in plasma for a long time. Its uptake into liver and other tissues is depending on the need of cholesterol, right. If your energy level is higher, your activity level is higher, this LDL will use, right. But if your physical activity level is lower, this LDL will not use and will circulate in a plasma for long time, right, and your cholesterol level will be elevated, right. This LDL is a bad cholesterol, right. Now, the rate of LDL uptake is regulated by the rate of LDL receptor synthesis in a particular tissue. This circulating LDL will uptake by LDL receptor in particular tissue, right. So, the rate of LDL uptake is regulated by the rate of LDL receptor synthesis in a particular tissue. Okay. Now, cholesterol ester of LDL is deesterified and used mainly for cell membrane formation. Okay. Now, the cholesterol released into the blood from degradation of membrane, right? This LDL is deesterified and will form cell membrane. And if this cell membrane is degraded, this LDL fraction will be released. Okay. So cholesterol will be released into blood from degradation of membrane, is rapidly incorporated in high density lipoprotein, which is HDL, and this is good cholesterol, right? Esterified with the help of an enzyme lecithin cholesterol acetyl transferase and transferred back to VLDL or IDL and complete its cycle. Okay, so this degradation of cell membrane will release HDL, and this HDL upon the cleavage of this lecithin cholesterol acetyl transferase enzyme will make VLDL or IDL and will complete the cycle, and this cycle will start again. Okay, the excess lipoproteins in plasma are phagocytosed by macrophages for disposal. Okay, when too much of lipoproteins have to be degraded in this manner, cholesterol is deposited in atheromas like in arterial walls and xanthomas like in skin and tendons. Okay, so these lipoproteins are phagocytosed and are excreted from body, but if this level is increased, they will accumulated in arterial walls and skin and tendons. Okay, and will cause a coronary artery disease, right, or this type of disease. Okay, now, raised levels of VLDL, IDL and LDL are atherogenic, while HDL may be protective because HDL facilitates removal of cholesterol from tissues by degradation of cell membranes, right? Now, hyperlipoproteinemia can be classified into secondary and primary. Okay, secondary hyperlipoproteinemia is associated with diabetes, myxoedema, nephrotic syndrome, chronic alcoholism, drugs, etc. Okay, whereas primary hyperlipoproteinemia is due to a single gene defect, which is familial and called monogenic or genetic, or it can be multiple genetic like dietary and physical activity related causes, polygenic or multifactorial. Okay, on the whole, LDL is primary carrier of plasma cholesterol ester and VLDL that of triglycerides, right? Now, hypolipidemic drugs, which will decrease the lipoprotein level, or you can say LDL level in plasma, right? In that, first is HMG-CoA reductase inhibitors or statins, which are most widely useful drugs for hypolipoproteinemia, right? So, examples of HMG-CoA reductase inhibitors are lovastatin, simvastatin, pravastatin, atorvastatin, rosuvastatin, pitavastatin, etc. Second is bile acid sequestrants, or you can say resins, cholestyramine and cholestyramine. Next is lipoprotein lipase activators, which is clofibrate, gemfibrozil, benzafibrate, fenofibrate, etc. Lipolysis and triglyceride synthesis inhibitor like nicotinic acid, and sterol absorption inhibitor, it is ezetimibe. Okay, now we will see one by one class. First class is HMG-CoA reductase inhibitors or statins. Okay, now 3-hydroxy-3-methyl glutaryl coenzyme A, which is HMG-CoA. Okay, it will convert into mevalonate, and this mevalonate is converted into cholesterol. Okay, when HMG-CoA is converted into mevalonate, it is cleaved by HMG-CoA reductase enzyme. These drugs inhibit HMG-CoA reductase enzyme and reduce cholesterol synthesis by 20 to 50%. Okay, this results in compensatory increase in LDL receptor expression on liver cells. Okay, if the LDL receptor expression in liver cells will increase, the uptake of LDL from plasma will increase and will decrease the plasma level of cholesterol. Okay, increased receptor mediated uptake and catabolism of IDL and LDL. Because HMG-CoA reductase activity is maximum at midnight, all statins are administered at bedtime to obtain maximum effectiveness, right? However, it is not necessary for atorvastatin and rosuvastatin, which have longer plasma half-life, right? Um, Other statins, except atorvastatin and rosuvastatin, have shorter half-life. Therefore, they are administered at bednight, right? Bedtime, okay? All statins except rosuvastatin are metabolized primarily by cytochrome P3A4. Inhibitors and inducers of these isoenzyme respectively increase and decrease statin blood levels. Okay, so statins are metabolized by cytochrome P3A4, right? If you are administer any inducer of this enzyme with these statins, right, it will increase the activity of this enzyme. Okay, and if the activity is increased, the metabolism of statin will increase. Okay, and the physiological activity or drug response will decrease. Similarly, if you are giving any inhibitor of this enzyme, its drug metabolism will be less and its adverse effect will be more, because it will remain for long time into our body. Okay, now drugs are lovastatin, simvastatin. Okay, lovastatin is a first clinically used statin, lipophilic and given orally in the precursor lactone form. Okay. Same way, simvastatin, which is a twice potent as lovastatin. Mechanism of action of these all statins are similar, right? But atorvastatin and rosuvastatin are more useful because this newer and most popular statin is more potent and appears to have the highest LDL cholesterol lowering efficacy at maximal daily dose of 80 mg. Okay, at this dose, a greater reduction in triglycerides is noted if the same was raised as baseline. Now, atorvastatin has a much longer half-life of 18 to 24 hours than other statins and has additional antioxidant property, and therefore atorvastatin is widely used nowadays. Same way, rosuvastatin, it has also a greater half-life of 18 to 24 hours, right, and greater LDL-CH reduction can be obtained in severe hypercholesterolemia patient. Okay, partly due to its longer persistence in the plasma, right? So these two drugs are most used. Adverse effect of all statins. All statins are well tolerated. Overall incidence of side effects not differing from placebo. Notable side effects are GIT complaints and headache, rashes and sleep disturbances, rise in serum transaminase, but liver damage is rare. Monitoring of liver function is recommended. Muscle aches are the commonest side effect. Myopathy is only serious reaction but is also rare. Few fatalities due to rhabdomyolysis are on record and myopathy is more. Okay. Statins are the first choice of drugs for primary hyperlipidemias with raised LDL and total cholesterol levels, with or without raised triglyceride levels, as well as for secondary hypercholesterolemia. Next is bile acid sequestrants or resins. These are the basic ion exchange resins supplied in the chloride form. They are neither digested or absorbed in the gut, bind bile acids in the intestine, interrupting their enterohepatic circulation, right? Fecal excretion of bile salts and cholesterol is increased. This indirectly leads to enhanced hepatic metabolism of cholesterol to bile acids. Now see, bile acids sequestrants are resins. Okay, so they are not absorbed into the body or not digested, right? But what they are doing, they are binding with cholesterol, and this complex is excreted in feces. Okay, and thus cholesterol level will be decreased. Okay, so this is the mechanism of action of bile acid sequestrants. Next is lipoprotein lipase activators, which is fibrates. These fibrates primarily activate lipoprotein lipase enzyme, which is a key enzyme in the degradation of VLDL, resulting lowering of circulating triglycerides, right? So lipoprotein lipase activators will activate lipoprotein lipase, which is responsible for degradation of VLDL and lowering concentration of triglycerides in plasma. Okay. Fibrates decrease hepatic triglyceride synthesis also, and a peripheral effect reducing circulating free fatty acids has also been seen. So it is a combination of effect. It activates lipoprotein lipase enzyme, therefore it will increase the VLDL degradation and will decrease the circulating triglyceride, as well as this decrease hepatic triglyceride synthesis, right? Therefore triglyceride level will more decrease. Okay. Clofibrate is an example of fibrates. Okay, it is a widely used hypolipidemic drug, but later evidence showed that it does not prevent atherosclerosis, therefore has gone out of use. Okay. Gemfibrozil is the another drug in the class of fibrates. So this is all about hypolipidemic drugs, right? Thank you.